to say that I really learned a lot during these past days, because I think we all share the interest of figuring out how can we determine immune responses and how does that help. And I was very happy when I got the invitation from Jeremy that we just have finished monitoring a very special case of a young man after lung transplantation. I decided, rather than giving you an insight what we normally do in the context of solid organ transplantation at Hannover Medical School, I would like to discuss with you the details of one very special patient where we try to have all the tools that we have at hand to use them to figure out what's going on in the patient. And the reason was we wanted to support and confirm the clinical decisions and help them to say, is it really happening what the clinicians intend to do with their decisions? Can we monitor that? And by that sort of substantiate their clinical procedure. So that's why we'll talk about the idea how we can identify the appearance of GVHD, rejection, and CMV infection after lung transplantation. And that's the collaboration with our pediatric pulmonologists, Nico Schwerk and Carsten Müller, and the transplant surgeon Gregor Barnecke, who was trained by Andrew Bushell here at Oxford. And that's why Gregor is one of the very few cardiothoracic surgeons who has really a substantial, deep understanding of the immune system. And it's a pleasure to work with him. As far as we are sort of between a PhD and a cardiac surgeon, there are sort of a lot of differences in between, but we have really a lot of fun working together. So at Hannover Medical School, we have the Integrated Research and Treatment Center Transplantation, which is funded by the Ministry of Research and Education. And the idea was to bring all the people together, including the ethics and quality management, but also the lab people like myself and Thomas Thum and Ulrike Köhl, to work together on the issue of cardiothoracic transplantation, abdominal transplantation, but also stem cell transplantation. And we have projects in the different areas, starting with organ preservation, where we are very much now in the process of trying to understand how you can improve organ preservation, and then all the issues that come along, including immunosuppression, endothelial components, and late complications. And I think this consortium of people, clinicians, scientists, but also other disciplines, really make sense to share the effort to improve the outcome of the patient and to use our different tools that we have to work together on solid organ transplantation. So talking about the tools, that's just the overview that most of you have at hand. So we use a lot of flow cytometry for the detection of the different subsets of immune cells, but I have a strong interest in epithelial and endothelial cells, and we also analyze urine, because for the kidney transplantation, that's one of the very precious biomaterials that you can study. Then we are involved also in immune function. I will refer to that, as many of you also, you were looking at T-cell responses, cytokine secretion, etc. But we are also very much into the question, can we use the microenvironment and cytokine networks to understand how things are coming along together, how innate immune responses are a prerequisite of the development of specific immune responses. And finally, we are using computer tools. So we're playing around with computers to figure out how can we have statistical methods for hierarchical clustering or principal component analysis who help us with this enormous data to figure out what's really important, which parameters are appearing together, where are possible links that we won't see if we would just look at these parameters one by another. So that's just sort of the overview how to have tools at hand that help us later on to understand what's going on in solid organ transplantation. My major interest at the moment is on lung transplantation, because lung transplantation is one of the very specified solid organ transplants where you have a very narrow time window. And it's clear that the organ preservation, the ischemia-reperfusion injury, is a major impact for the immediate response after lung transplantation. And I will show you only one glimpse of what we are trying to understand and how we can improve lung transplantation. And the special case I will refer to you today is a young man who was transplanted at Hannover Medical School by Gregor Warnecke and developed a series of complications, and we tried to follow that patient, as I said, to help the clinicians to make their clinical decisions and to get these patients in a stable condition for a longer period of time. That's one of my most favorite lecture series slides, and I don't have to refer here in Oxford to that detail, but I think that transplant immunology really contributed a lot to many of the mechanisms we're talking today. And of course, Sir Peter Miramar and also Sir McFarlane Burnett, who have been mentioned before yesterday, were absolutely instrumental here. And you see here also that even from the clinical part, solid organ transplantation had a major impact also on the development of the surgical techniques, but also it was coming along that we need to understand the immune system. For us, that's natural. I just would like to emphasize that this year there's a 50-year anniversary of Christian Barnard, who did the first heart transplant. And so my idea was that we should have an excursion at the IFB to Cape Town, but somehow people don't listen to me when I mention that. But this is a picture that I took at Beaufort West, which is the small city where Christian Barnard was born. It's a bit north of Cape Town. And that's the room sort of where you see the first ECMO, the extracorporeal membrane oxygenation machine, that gave him the chance to do the first heart transplant, where the Americans, especially the Boston colleagues, are not very happy with because they didn't have the device. That was the reason why he was the first one with a heart transplant. Here you see Christian Barnard, here you see his boots, and here you see a picture of him in the operation room. That also tells you something about cardiac surgeons. A room like that is something that you would not find for every MD who has made a major contribution, but for Christian Barnard, that's sort of the one of the things that you discover that he was a very special character, and in South Africa he's quite well known. So yesterday also another big issue that's coming along with organ transplantation was mentioned, and Tim mentioned Sir Roy Kelm. He was not only the one who discovered that the liver is a very special organ with tolerogenic properties, he also discovered that we need immunosuppression, and he was the first actually to use cyclosporin in the clinic. He's a surgeon, and he's a wonderful character, and he's a painter. So you see here his own paintings that he draws from his patient and the OR, and he is really someone who, as a surgeon, said at the time when they started with immunosuppression, everybody said it can't be done. But the surgeons, very pragmatic, thought we have to test whether cyclosporin would be a substance that can perform immunosuppression so that we can do organ transplantation. And after that, there was a development of some of the new mTOR inhibitors, for example, here. Then we have the new era of the co-stimulation blockers. And we heard yesterday and today a lot about the molecules that have a strong impact on immune reactivity. And this would be one of the pictures where you see how many molecules are around where we know they contribute to T-cell activation. But there have been a lot of developments going on for new drugs, and you see them here in the middle. But to be honest, for solid organ transplantation, we are down to what Sir Roy Kelm used. So we're really down to, at the clinic, tacrolimus and cyclosporin, and sirolimus as mTOR inhibitor, and MMF as purine interference agent that blocks proliferation. So basically, solid organ transplantation has not made that progress, and this is something a lot of people are discussing, why this is so difficult here. And I think there is room for improvement in solid organ transplantation because the drugs are there, but for several reasons they have not made their way to the clinic yet. So after this introduction, I would like to emphasize a very special point that for us immunologists is quite surprising. We are all aware of that. Of course, for stem cell transplantation, the best matching has to be performed in order to prevent graft versus host disease, for example. For the kidney transplantation, the clinical routine is typing of HLA-A, B, and DR, particularly. Sometimes, if you're lucky, you have even DP and HLA-C, but basically it's on A, B, and DR. Surprisingly, for the liver, the lung, and the heart, the HLA typing is there, but nobody cares about it. So these organs are transplanted in a complete mismatch situation. And that's for immunologists something where you'd say, whoa, wait a minute. If you have a complete MHC mismatch here, you would expect autoreactivity. That's exactly the case. There are many reasons, especially organ shortage, because there would be no chance to get a lung or a heart with MHC matching. But of course, this has a price. And the price is either, although the liver is, quote, a tolerogenic organ, it needs immunosuppression. And there is, of course, the complication of rejection and fibrosis, in rare cases even GVHD. So you do transplant an immune system with the liver and you get GVHD in the end. It's not easy to handle in that situation. For the lung, you have primary graft dysfunction, which is the early complication, and at later stages, about 1 to 2 years, there's a development of bronchiolitis obliterans syndrome, where the airway are getting smaller and smaller because there's like a hyperproliferation, which is a sign of chronic rejection. So again, the lung has a very particular impact on its reaction on immunosuppression. And for the heart, there's the chronic allograft vasculopathy, again, something that affects primarily the blood vessels that are connecting the heart. So the immunosuppression here is really a big issue, and I will show you in one example how we try to understand what's going on after lung transplantation in a very special patient. I mentioned the Massachusetts General Hospital already with the colleagues in Boston. German Madsen and colleagues are certainly, with David Sachs, some of the pioneers who try to understand how one could establish tolerance protocols. And they are very much focusing on bone marrow-based tolerance protocols. I won't go into detail, but this is the combination of bone marrow transplantation or stem cell transplantation with kidney transplantation. They were able to achieve long-term tolerance with that procedure. It's certainly nothing for hundreds of patients, but in principle, it's very interesting that it works. You've maybe heard about the one study, conducted and organized by Ed Geisler in Regensburg. And the one study was putting their money on regulatory cells. And it's one of the very exciting studies where they really took the effort to say, we want to have a study where the one is the one clinical protocol of kidney transplantation managing with tacrolimus and MNF primary. So the standard arm was the one comparator arm. And then they used different regulatory cells. So some people are working on MREGs like at Geisler in Regensburg, or Tregs at the Charité Birgit-Sawicki in Berlin or in Oxford here with Andrew Bushell again. And then also different types of regulatory T cells, even regulatory dendritic cells. And they try to establish a protocol where they say, can we prove that there is a clinical issue with regulatory T cells or regulatory macrophages? And is it a safety study? Can we say we can bring these regulatory cells into the clinic in form of a study? At Geisler and Birgit-Sawicki are currently putting the clinical results together. They had an enormous effort on immune monitoring, and that's really it took many years to establish all the techniques, but they will certainly show you can bring regulatory cells into the clinic. It's an enormous effort, but if you monitor very precisely what's going on there, you can also have a clinical outcome linked to immune monitoring outcomes and to show what do we have to measure to see whether this has a success. So this is sort of the introduction on what do we need to know about solid organ transplantation today. We are working together with our clinicians here very much on the question, the cold static preservation is the standard of care, which means the organ, especially the lung, is packed into a plastic bag with perfusion solution, and it's kept on ice for maximum 6 to 8 hours and then transplanted. And this cold ischemic reperfusion injury is one of the hallmarks of the early complications after lung transplantation, because there's no airway gas exchange, there's ischemia, hypoxia, and the lack of oxygen. And there is the cold temperature, it has a low metabolism, but despite that, there's an inflammatory reaction coming from the organ and the immune system. And this is one of the major complications early after transplantation, and we're trying to understand it a bit more. In the review by Andreas Linkermann, he showed that even the donor event of brain death is having a systemic effect. He thinks it's mediated by cell death. I don't really sort of agree 100%, but this is certainly one of the mechanisms why inflammation is induced during the donor process, so to speak. And the systemic effects of these death events coming along with other events associated with brain death are going to the organs that are later on transplanted. So during the explantation process, you have inflammatory reactions that impinge on the outcome later on. And this has very much to do with the question, how do these organs recognize there is brain death, there is no ischemic situation at the moment, and there is no oxygenation here. So we are interested in trying to understand, can we reduce ischemic reperfusion injury? And this is something where we are trying to focus on the lung very much. If you have the lung that you have, then you have normally 3 compartments you have to look at. This is the airway compartment, and many people are talking about bronchoalveolar lavages, and you get the BAL liquid only if you come to this 3rd, maybe 4th bronchus here. So you will have the big branches, you will never reach the alveoli where the real gas exchange occurs between the epithelial layer and the endothelial system. These macrophages are certainly not swirling around in our lungs. They are adherent to the endothelial layer, which is here mediated by the epithelial cells here. In ischemic reperfusion injury, the entire system gets inflammatory signals by the cold temperature and also by the hypoxic events. So you have activation of macrophages, but also on the endothelial compartment, including the epithelial layer here, which leads to production of cytokines and chemokines and other pro-inflammatory factors, including ROS. And you have this kind of leakage syndrome that leads to a loss of the integrity of the endothelial layer. The question is, can you improve that situation and can you prevent this inflammatory reaction? We tried to understand that in an international multi-center trial, the INSPIRE trial, where there is a comparison of the standard of care procedure, the cold ice bath. So we tried to compare the blood of the recipient before and after transplantation and the perfusion solution, which is the liquid where the lung was sitting in for 6 to 8 hours, and then also the postoperative time points. We're looking at a lot of flow cytometry analyses of different cell types, but also the secretion of cytokines and chemokines. We focus on the endothelial integrity by molecules regulating endothelial exchange and endothelial function. And there are some chemokines and sort of the typical pro-inflammatory factors that we also are looking at. You'll never know really where these factors are coming from because basically all of the cells can produce that. And this is just the only picture I would like to show how we compare this cold ischemic standard of care procedure with the organ care system, which is one of the new devices that are made to place the lung into that system here for 6 to 8 hours. It's warm, it's oxygenated, and it is perfused constantly with erythrocytes. Some of you may be familiar with the OrganOx system for the liver transplantation. That's a similar device here for the lung. So the lung is sitting here and normothermic oxygenated for 6 to 8 hours. If you compare the perfusates here and here, you see in this heat map analysis, it's like a black and white picture. You have a pretty good insight what's changed during this normothermic oxygenated perfusion here. We have a quite nice circle of events why this situation here improves clinical outcome because it reduces ischemic perfusion injury. We're using also computer games to identify what are the hallmarks, what are the most important factors to discriminate between standard of care and the organ care system. And something is related to IL-6 and IL-8, what you see here. We have a quite nice feedback loop where we think IL-6 is in the center of this inflammatory reaction, but the negative regulators in the organ care system can reduce this inflammatory reaction. But for today, I won't go into detail. I would just like to show you that this is something where we now really focus on figuring out what are the mechanisms that improve organ preservation here at that level, even before the organ is transplanted into the recipient. Once it is transplanted, then the question occurs, what's happening next? There is the implementation of immunosuppression, and then the clinical monitoring, how the patients are doing well. And this is the case I would like to discuss with you. It's a young man, 17 years old. He was suffering from cystic fibrosis, and he was listed for lung transplantation in February of this year. He got a bilateral sequential double lung transplant by Gregor Warnecke. The CMV status, I come back to that, is always like a high-risk combination. When the donor is CMV positive, the recipient was CMV negative. He did quite well, so he was extubated quite easily. He left the ICU the next day. Need of oxygen supply was only a few days, and the discharge to rehabilitation was quite normal after a couple of weeks. And so this was the lung picture, so everything seemed to be okay for the moment. But then what happened is this. A couple of weeks later, the patient presented after rehabilitation to the clinicians with an enormous appearance of skin rashes here. And the question was, is this infection or could this be something else? To make a long story short, they treated for infection first, but it didn't get better, it got worse. So after they stopped antibiotics, it was clear from a skin biopsy that it is a very rare case of graft versus host disease after lung transplantation. We know in the meantime that a lot of immune cells are co-transplanted with the lung and the liver, and sometimes they can mediate GVHD. In the literature, GVHD after lung transplantation is associated with enormous worse outcome because there is no real guidelines how to treat such a patient. Now, Gregor Warnecke decided at this point, where this was the constellation, this was the standard treatment here, Gregor Warnecke decided against the literature not to improve immunosuppression because he would say, if I have GVHD, I have to stop the process. He decided we lower the immunosuppression by taking out MMF. And the idea was that if you could prove that there are donor cells in the recipient, we should be able to reject those by lowering immunosuppression, because then the recipients would act against the donor, and this is exactly what we could show. The HLA-A32 is the donor-specific HLA molecule, and Franz Klaas in Leiden has a lot of antibodies specific for alleles. So we asked him for support, and we got the antibody from him very quickly. We could show that at the patient, when he came back and we were involved trying to understand what's going on here, that there were up to 3% of the CD4 or the CD8 T cells were coming still from the donor. 3 months after transplantation, these cells were still there, and the idea was these might have been the ones that mediate GVHD. So reducing immunosuppression by taking out MMF led to a pretty quick reduction to almost not detectable levels of those donor T cells. So that was the good news. They could reduce the GVHD mediating cells, and we could prove that by showing that these donor cells rather disappeared. But then the next problem came up. Oh yeah, and here, interestingly, the NK cells disappeared with a little delay, but they also disappeared, but the B cells are still there. So we still have a mixed chimerism here in this patient with a B cell compartment. We don't know exactly why they don't leave, but they're still persistent. That's quite amazing. So the B cells very often behave differently from the T cells. But then the question was, okay, we have here the GVHD situation. This guy was really getting better. So this was the good news. The bad news was that the lung function went down. And that's not surprising for us as an immunologist. If you improve the rejection, so you want to get rid of the GVHD cells, of course, you're getting close to the edge of rejection because the lung has the same MHC like the donor cells. So then you got a lung rejection phase. And this was exactly what happened here clinically. That is that it must be rejection. Now we need to do something. And then we said, okay, we need an HLA-A32 positive cell. We didn't have donor material, unfortunately, but we had transfectants and cells that are expressing HLA-A32. And then we did ELISpot analysis of the PBMC of that patient, and you see the course here. There was already this underlying frequency of alloreactive T cells that you can measure with gamma interferon ELISpots, but it increased exactly at the time when the GVHD was going down. Then the rejection came up, because this was the idea, to get rid of the donor cells, but the collateral damage hit the lung, and I think this is the increased frequency here. So then it was clear that with this immunosuppression, they have to do something, and the guidelines would say you need to have steroids to suppress the rejection episode to preserve the lung that was transplanted, and that's what they did, and this ended up in a very late but a decline of the allospecific T cells. But then the next problem came up, that if you have steroids and you have a situation where the donor is CMV positive and the recipient is CMV negative, you have to be aware of that. CMV takes a chance and it infects the recipient. It was coming with the lung into the recipient, and now it starts infection. And clinically, this was exactly what happened. All of a sudden, there was CMV detectable in the recipient's blood. We used the CMV or CF peptides to look for CMV-specific T cells in the ELISpot, and you could see they were really absent until you had this crisis here where there was the steroid treatment that gave CMV the chance to come up, and that with a little delay, you see here the appearance of gamma interferon-producing spots here. But we used in this assay, like we always do, the CF peptide complexes where you have the PP5 epitope, and you have also the B7 and the A2 PP5 peptides in here, but also others. So this was the question. We do see the appearance of CF-specific T cells here with the gamma interferon ELISpots. The question is, are they really specific for CMV? And this was the point where we started to analyze that in more detail. And this is to show here that I think it's one of the very often published examples where you really see you have a CMV increase, and this is the numbers of neutrophils positive for CMV particles here. So you have a peak here, but at the time when there is a specific T cell response coming up, you can really suppress CMV activation and CMV infection, and CMV is controlled, and that's exactly what we want to see. The question was, are these T cells really CMV specific? Not surprisingly, we asked for support and purchased the pentamer here. And of course, we wanted to see whether the so-called immunodominant epitope, the A2 NLV peptide, would really hallmark for us the specific T cell response. And it's very easy to see that actually it did. So we see here the very nice increase of specific T cells recognizing the A2 NLV peptide complex. We also wanted to see whether the VLE peptide would also give a response, and you see that there is very marginal expansion here. So the major of the response must have been performed by clonal or oligoclonal expansion of A2 NLV peptide specific CD8 T cells. So we could really show that this patient, with all that history, it was able to mount his own CMV specific response. So when you see that, then we also wanted to know, do we see some kind of change in the naive central memory, effector memory, etc. subsets? And we used CD28 and CD27 because Martina Seester has shown that the CD28, 27 double negatives, so they would be here in the lower left corner, should be the so-called CMV-specific T cells. It doesn't really look like that. If you gauge on the blue cells, these are the pentamer positive cells, you see here that there are some naive proportions here, and they seem to be stable, they remain over time. But then most of the cells quite easily lose CD28, but they still are either 27 positive or negative. So I think there's would have expected more change in the subset distribution here, but we could discuss that why this is not the case. If you just take the normal CD8 compartment here in gray, then you see here that there's a basically stable distribution of all four subsets when you take CD28 and 27, but the CMV-specific ones seem to be rather a small pool of naive phenotypically naive T cells accompanied by central and effector memory cells. So we see that there is a low frequency of these cells, but we can see the expansion. We can see that there's a specific response that seems to control CMV infection, and that's just the figure here. When we overlay here the CMV positive neutrophils in the peripheral blood and the frequency of the pentamer positive cells, you see the same picture. As soon as they come up, CMV has no chance. The T cells seem to control CMV infection. That was the good news. And if you take that as an overlay with the clinical course, then you can nicely see that the series of events was accompanied by a later appearance of specific CMV immunity. We also were monitoring a lot of cytokines in the peripheral blood, and when you have the cytokines, then you can't really say where they're coming from. So here the picture is more complicated, but what you can observe is that when you really have a steroid pulse, like you see here, then you see a drop in the typical activation markers like soluble CD25, for example. Here, you have a little earlier onset of gamma interferon that goes down. If you have IL-17 in the system, you see these two drops here. These are exactly the time points where the steroids were given. So the cytokine response it's an overlay, of course, of different specificities. But you see here, if steroids are given and they really make an impact, you can see that and monitor that by the cytokine levels. So after that kind of really busy time for the patient, we could show with our immune monitoring tools and refer that back to the clinicians that indeed this was a series of GVHD followed by rejection and CMV infection, and at the moment the patient is doing fine and everybody's happy that he's made that because he's one of the very few cases in the literature who survived that series of events with his new lung. And we're always happy when monthly we get a blood that we can see he is really fine and doing well. And this tight interaction between the clinicians and us was certainly something where we could support the clinical decisions by saying, and now he has really a CMV immunity mounted by himself, and he should be safe for CMV infection now. So with that, I would really like to conclude with you that this was one of the cases where we have now at the moment more than 100 patients that we're monitoring, but he was the only one with GVHD. And you could say that GVHD was coming presumably by donor cells that have been co-transferred to the recipient. The reduction in immunosuppression did what it should do. It was the rejection of those GVHD mediating cells, but at the same time there was rejection, and this was associated with an increase of HLA-A32 specific T cells. Well, when the steroid boilers got under control of those and they went down and the gamma production went down, then there was accompanied a CMV infection due to the high risk status of a CMV positive donor. And with a delay, there was the chance to mount his own immune response, and we were not surprised to see it was the so-called immunodominant peptide complex that was recognized by those specific T cells. And if you monitor the cytokines, we at least can say there's an impact on steroid treatment when we monitor those quite closely and have a lot of factors that we're looking at simultaneously. So with that, I would like to thank you for your attention, but also my group who was very much involved in trying to figure out what's going on with these patients in particular. These are the pediatricians and the cardiothoracic surgeons. And since Andrew Bushell mentioned him several times, he was one of the first colleagues who introduced me into the field of solid organ transplantation. I owe him a lot, because he also was always supportive between the cooperation between the cardiothoracic surgeons, and Gregor was in his lab for many years. And so one of the reasons to come to Oxford was we had a plan that we had tea together, and this did not happen because you all know that he died, unfortunately, last year. So I would like to dedicate my presentation to Andrew, because he was a great colleague, and I think he influenced the field, and together with Catherine Wood, a lot. And we would not have that deep insight into transplant immunology without the Catherine Wood and Andrew Bushell lab. So finally, I would say, with T-cell biology, as much as we love T-cells, it's like cleaning up Paul Klee. If you try to do that, and you use computer games, you have a situation like that. This is a Paul Klee, and you clean up that. But transplant immunology, like tumor immunology, is probably more like Juan Miró. And if you clean up Juan Miró, it looks like that. And I think we're not there yet. That's why we are doing research and why we try to figure out new systems, new technologies, and new tools. But that's the ultimate goal, and I think it's fun to work on that, and especially fun to discuss with you. So thank you for your attention, and I'm happy to take questions.